Welcome, exam candidates and medical coders, to this explainer. Look, if you've ever stared at a dense cardiovascular chart and just felt completely overwhelmed, you are absolutely in the right place. Today, we're putting on our detective hats to definitively unpack the core ICD-10-CM rules for systemic hypertension, that persistent elevation of resting blood pressure, and hypertensive heart disease. Whether you're prepping for your CPC or CCS exams or just doing daily audits, this is a make or break skill. So let's dive right in and decode these charts together. Here is our case file for today. We'll start by setting our essential hypertension baseline, then we'll break down the crucial with guideline, map out the specific hypertensive heart disease rules, tackle heart failure combinations, walk through a real clinical case, and finally wrap up with a cardiorenal teaser.
All right, Section 1, let's establish our essential hypertension baseline and identify our primary suspect.
At the very center of our investigation is code I-10 for essential or primary hypertension. Clinically speaking, we're talking about blood pressure measurement thresholds hitting 130 systolic or 80 diastolic millimeters of mercury or higher. Providers typically diagnose this using a standard sphygmomanometer, often backing it up with an ECG and various lab profiles. Now, if the hypertension is secondary to some other condition, you'd pivot over to category I-15. But here's the really important part for I-10. Whether the documentation shows the patient's hypertension is perfectly controlled by drug classes like ACE inhibitors, ARBs, beta blockers, or calcium channel blockers, or if it's completely uncontrolled and off the charts, your coding directive is exactly the same. The control status literally doesn't change your base I-10 code. Moving right along to Section 2, the with guideline, the assumed accomplice.
Okay, this concept is the absolute linchpin of cardiovascular coding. The with guideline is this incredibly powerful ICD-10-CM directive. It legally, well, in the coding sense anyway, assumes a direct cause and effect relationship between hypertension and specific heart diseases. Specifically, we're looking at heart conditions classified under categories I-51.4 through I-51.7, as well as I-51.89 and I-51.9. The real magic here is that the guidelines allow you to combine these into category I-11.9, which is hypertensive heart disease without heart failure. You assume the hypertension caused the heart disease even if the provider doesn't explicitly write the words hypertensive heart disease in their notes. The guidelines basically connect the dots for you.
But as with any good coding rule, there's a catch. We have our assumed cause and effect, where you combine them into a single code like I-11.9, but there's one critical exception where you have to code them separately. You only break that assumption and separate the codes if the provider explicitly documents that the heart condition is completely unrelated to the hypertension. If the chart straight up says myocarditis unrelated to hypertension, well, the assumption is broken. Otherwise, you assume they're partners in crime and combine them. So, Section 3, let's map out these hypertensive heart disease rules mechanically.
Now, when you apply that with guideline to conditions like myocarditis, other ill-defined heart diseases, or unspecified heart disease, you assign I-11.9 for hypertensive heart disease without heart failure. But listen closely because this is huge. Normally, you're required to append an additional secondary code from category I-51 to capture the exact condition, but there is a critical October 1, 2025 guideline update that you absolutely must write in your manuals right now. Are you ready? If you are assigning I-11.9 for myocardial degeneration, which is I-51.5, or cardiomegaly, which is I-51.7, you assign only I-11.9. I'll say it again. Do not assign an additional I-51 code for those two specific conditions starting October 2025. It's just the I-11.9. That is a massive rule change to watch out for.
Let's step it up in Section 4, coding heart failure combinations, escalating the diagnosis. The moment heart failure enters the clinical picture, everything escalates. Your primary code immediately upgrades from I-11.9 to I-11.0, hypertensive heart disease with heart failure. But you are definitely not done yet. You are strictly mandated to report an additional secondary code from category I-50. See, code I-11.0 just tells us that heart failure exists, but that I-50 code documents the exact type. Is it systolic, diastolic, combined? You absolutely must provide both codes to paint a complete, compliant clinical picture for the auditors. All right, Section 5, let's put this into practice with a clinical case walkthrough. Let's review the evidence in this file. We've got a 68-year-old male presenting with gradually worsening exertional dyspnea. His BP is elevated at 158/92, and the chart notes his hypertension is theoretically controlled on medication, though clearly elevated today. His echocardiogram reveals left ventricular hypertrophy, or LVH. But here is the massive clue the provider left us. The physical exam explicitly states no signs of HF. They checked for JVD, rails, all of it, and definitively ruled out heart failure. So, how do we crack this? Step 1, we recognize the documented hypertension. Step 2, we note that explicit lack of heart failure. Step 3, we apply our presumptive with guideline, connecting the hypertension directly to the left ventricular hypertrophy. Because there's zero heart failure, we can't use I11.0, right? So, step 4, we arrive confidently at our single correct primary code, I11.9, hypertensive heart disease without heart failure. See how just trusting the guidelines walks you right to the correct verdict? Finally, Section 6. Let's do a quick summary and tease our next big topic. Lock these rules in your mind. I-10 is your baseline for essential hypertension. The with guideline automatically links that hypertension to specific heart conditions. Code I11.9 generally requires an additional I51 code, but remember that October 2025 update. If it's myocardial degeneration or cardiomegaly, it's I11.9 alone, no extra code. And lastly, code I11.0 plus an I50 sequence is completely mandatory the moment heart failure shows up. Master these and you are golden. So we've totally solved the mystery of primary hypertension and hypertensive heart disease in this explainer. But let's be real, in the clinic, medicine is rarely that isolated. What on earth happens when chronic kidney disease enters the fray? How do you juggle hypertension, heart failure, and chronic kidney disease all in a single patient encounter? Join us next time as we investigate the cardio-renal connection and the intricate world of I12 and I13 combination coding. It's a real puzzle and you won't want to miss it. Keep studying, stay curious, and I'll catch you in the next explainer.